Welcome, everyone. My name is Jennifer Noel, and I'm the Program Manager for the Education and Outreach Core at the University of Vermont Center on Rural Addiction. I'm also here with Education and Outreach Research Assistant Eleanor Broy and CORA Program Advisor Ashley Mallett, who will be helping to run this webinar. Thanks again for joining. The Community Rounds Workshop Series is a live webinar series held monthly by the University of Vermont Center on Rural Addiction to provide opportunities for health professionals and community partners to learn and ask questions. We discuss topics related to science-based best practices for substance use disorders, and sessions usually include about 45 minutes of presentation, followed by 15 minutes or so for questions and conversations. So we are excited to get started with our webinar, but before we begin, I do want to go over a couple of reminders. We encourage you to ask questions, so feel free to enter them into the Q&A box during the session, which can be found on the bottom of your screen as shown by that red arrow. And then we will review them during the Q&A period at the end. And if you need to step away before the Q&A period, this session is being recorded and will be delivered along with the slides to your mailbox next week. If we run out of time for all the questions, we will follow up with you via email. After the speaker has finished his slides and just before we have our Q&A, we are going to share a very short poll to assist us with our evaluation. And we'd love for you to complete this poll. It should take about 1 minute, and it's going to appear right in the middle of your screen. If people are comfortable, please use the chat box to introduce yourself to the group by sharing your name and your organization and what community that you're coming from. We're also really grateful for any comments that you want to share about the webinar itself during the webinar or at the end of it. Be sure to select panelists and attendees when you use the chat feature so that your peers can connect with you. We're also pleased to offer live captioning at today's event, and to access the captions, please see the chat. We will be providing a link in the chat. You might be able to hear my dog snoring in the background. Sorry about that. Continuing education credits are available for both those who attend this session live and those who watch the recording within 1 month of the live event. During the session, we will share the link in the chat box for instructions on how to claim your credits. And you'll also get instructions via email when you receive the recording and the slides. If you have any questions, you can always contact us at cora@uvm.edu. We do ask that you claim these credits within 30 days of the live webinar. And the process for claiming credits is the same for attending live and for watching the recording. There are no disclosures for this community round session, and all potential conflicts of interest have been resolved. If you have any questions about the Zoom platform, please use the chat box and we'll do our best to resolve any problems. So I'm going to stop share now. And Dr. Klemperer, you can start to share your slides if you want. First, I'd like to welcome Dr. Diane Galima, who will be introducing our speaker today. Dr. Galima is an associate professor in the departments of psychiatry and psychological sciences at the University of Vermont. And Dr. Galima, I'll hand it over to you.
Thank you, Jenny. So it's my pleasure today to introduce Dr. Elias Klemperer as our speaker today. So Dr. Klemperer is an assistant professor at the University of Vermont in the departments of psychiatry and psychological sciences. And he is an investigator that's housed in the Vermont Center on Behavior and Health. Dr. Klemperer's research primarily focuses around developing clinical and regulatory interventions to reduce harm from tobacco use, with a particular focus on nicotine reduction and dual users of cigarettes and e-cigarettes. In addition, Dr. Klemperer has a growing program of research on the treatment of opioid use disorder among people who are incarcerated or recently released from incarceration in rural communities. And so, as I said, it's my pleasure to introduce Dr. Klemperer and to hear from him today. So now I will turn it over to him.
Thanks, Diane. Before I get started, can you see the large Center on Rural Addiction without my notes, the full thing here? Great.
Yes.
Slides are working.
Yes.
Thanks for that introduction. I'm very happy to be here today. Grateful to the Center on Rural Addiction for having me come talk about this important topic. As already mentioned, I'll be talking about body of research on motivation phase interventions to treat tobacco use, and specifically thinking about how we can apply this to people with opioid use disorder who smoke cigarettes. So you've already seen this slide, so I'll skip over this. So before I get started, I'd like to just walk you through a brief outline of the topics that I plan to cover today. To start with, I'll orient everyone to tobacco use in rural communities. We are the Center on Rural Addiction, and this is an important topic, especially here in Vermont, where many of the patients with opioid use disorder and tobacco use disorder live in rural communities. Then I'll go on to talk a little bit about prevalence data on tobacco use among folks with opioid use disorder. Then I'll spend the majority of the presentation today talking about treatments and interventions for people who smoke who are not ready to quit smoking. This is a particular area of interest and a focus of my research, so I'll be covering some of that work. We'll end with the culmination of these topics and talking a little bit about tobacco treatment toolkits, which are distributed by the Center on Rural Addiction here, and supported by the evidence that I'll be talking about in the presentation today. Then one with some questions after that. Okay, so to get started, this is a slide some of you may be familiar with on this call here. Tobacco use is more prevalent in rural counties and rural states throughout the United States. And we see here is data from nationally representative data from the National Survey on Drug Use and Health, demonstrating that indeed more people per capita smoke in rural communities. But what is less commonly known is not only is smoking more common, but the harms from smoking appear to be greater among people who smoke in rural communities. So rurality is associated with higher smoking-associated cancer and mortality. So this is an urgent issue that needs to be addressed in rural communities. Figure in this slide is from a recent paper by Maria Parker and colleagues, and Andrea Valenti, part of the Center on Rural Addiction, demonstrating that this is not a new issue. This is something that has been pervasive in the United States. Here you see on the slide over the past decade. So to orient you to this figure, what you're looking at is the quit ratio, or the proportion of former smokers over ever smokers. And the orange, the brighter bar there, the orange color, represents people in urban communities, whereas the blue, or the gray blue, represents rural communities. And what you can see is the quit ratio, or the ratio of former smokers to ever smokers, is consistently lower over the past decade, indicating that this is not a new problem. This has been around in the United States for some time here. So if you haven't already read the paper, I'll just give a brief shout out, recommend this paper highly. It gives some great information on the foundation for why treating people with tobacco use disorder in rural communities is just so important. So moving on to thinking about the co-occurrence of tobacco use and opioid use disorder, which is really the focus today. What we know is tobacco use is much more prevalent among people with opioid use disorder in the United States. So these, again, are nationally representative data where we see that there's a threefold higher prevalence of cigarette smoking among people with opioid use disorder versus without opioid use disorder in the United States. And similar to the increased prevalence in rural communities, the increased prevalence among people with opioid use disorder is not new. This has been around in the United States for a while. This is longitudinal data demonstrating the increased prevalence of opioid use disorder among people who smoke from 2002 to 2017. Here you see the gray squares and the gray triangles at the bottom represent never and former smokers, whereas the circles and diamonds at the top represent current daily and non-daily smokers. And you can see that divide is pervasive. It's been around here for a while. So all of this is demonstrating need, that we need to be providing tobacco treatment for people with opioid use disorder. But I'll just sort of hammer home this point even more. Not only is smoking more common, but it increases cardiovascular disease and is actually the second leading cause of death for people with opioid use disorder, such that there's a 4-fold higher mortality rate among people with opioid use disorder who smoke compared to people with opioid use disorder who do not smoke. Now, the important piece, I think, of these last 2 bullet points, which is something that I think historically has been overlooked. Tobacco use is associated with increased likelihood of returning to other substance use among people in recovery, and smoking cessation does not disrupt treatment for opioid use disorder. So, you know, there has been a commonly held belief that patients with opioid use disorder, targeting smoking cessation or asking them to quit could disrupt things, could cause return to opioid use. But what we see over and over again is that's simply not the case. And in fact, it's very helpful to be treating tobacco use among people in recovery or who are working on recovery from opioid use disorder. Bottom line here, tobacco treatment for people with OUD is crucial. So what do we know about treatments for tobacco use among people with opioid use disorder? Well, first, it appears as though in meta-analyses, brief counseling alone is often insufficient to treat tobacco among people with opioid use disorder. We need more than that. There's good evidence to suggest contingency management is effective for smoking cessation. So this is the practice of providing financial incentives for smoking abstinence. Often a barrier for implementing contingency management is setting this up in existing treatment systems. But we also know that pharmacotherapy is effective for treating smoking among people with opioid use disorder. To give you an example of the effect size here, we see that nicotine replacement therapies, a form of pharmacotherapy, increases smoking cessation between about 1.5 to 3.5 fold at a 6-month follow-up compared to placebos. It's worth noting, though, that effects appear to be reduced if we compare smokers with opioid use disorder to those without opioid use disorder, but it's still effective. So we still want to be providing pharmacotherapy to folks with opioid use disorder. So pharmacotherapy is effective. We have some barriers to treatment that I'd like to talk about here. First, it's worth noting that broadly speaking, smokers with versus without opioid use disorder are much less likely to quit smoking. Again, highlighting the need to get people engaged in treatment, and specifically here thinking about pharmacotherapy. And this is demonstrated by national data that you see in the figure on the right there. So what are the barriers to engaging people with opioid use disorder who smoke in effective treatments for smoking cessation? Well, nicotine dependence among people with opioid use disorder is often higher than those who smoke without opioid use disorder. It's for a number of reasons, but one might be due to potential opioid nicotine interaction in the brain, where the two drugs interact to facilitate even greater dependence on cigarette smoking, often resulting in heavier smoking among people with opioid use disorder. Other barriers include co-occurring psychiatric disorders that are more common among people with opioid use disorder, and then low treatment engagement, which is a topic I'd like to focus on for the remaining slides in this presentation. And engaging someone in treatment involves a number of different factors. I'll be focusing on ways to increase motivation, which is one important way to increase engagement in smoking cessation treatment. Before I get on to that body of research, I want to recommend this systematic review here. And for anyone interested in this topic, providing smoking cessation treatment to people with opioid use disorder, this covers a lot of very useful information. So when we're thinking about building motivation for engagement in smoking cessation treatment, a big construct or a big thing that is often front and center to address is just simply readiness to quit smoking. Patient comes into your office and says, yeah, I'm interested in quitting someday, but not today. Well, that's actually a very common occurrence. So most adults who smoke cigarettes, regardless of their history with opioid use disorder or not, want to quit someday, but are not interested in quitting in the near future, in the next 30 days. Now, you'll notice as an aside, I'm using this term readiness to quit smoking. That's because there's a lot of different factors that we think are wrapped up in the readiness to take that first step. Could be motivation, which is often referred to. Could be self-efficacy, confidence and ability to quit, or simply intention to go ahead and make that quit attempt regardless of motivation or self-efficacy. So I'll be using this term readiness to quit here. So, that first bullet represents data for nationally representative data for people who smoke in the general population. But what we know is actually residents of rural communities are less likely to report readiness to quit in the next 6 months when you compare them to urban residents. So this issue of increasing readiness to quit, to engage in treatment, becomes even more important with our rural patients and clients. When it comes to people with opioid use disorder, I don't have great nationally representative data on how their readiness to quit compares to the general population, but large clinical trials demonstrate that generally speaking, they report similar motivation to quit as the general population, which is to say that means that most people on any given day are not ready to quit now, but do want to quit at some point in the future. So there's an important factor to consider when we're thinking about increasing readiness to quit smoking, increasing that engagement. And that is readiness to quit is a fluid construct. This changes quite rapidly. So in contrast to prior models where you had this idea that we would build motivation linearly over time, what we see is actually people's motivation to smoke or quit smoking changes quite rapidly. So I'm going to talk about a body of research that was really spearheaded by a prior faculty member here named John Hughes. He has a number of natural history studies where he gathered a group of people who smoke cigarettes who said, I don't want to quit in the near future, and then simply measured what happened over time with their cigarette smoking. And so what you see here on the screen is what's called a pixel graph. Each row represents an individual participant who smokes cigarettes and at baseline said they're not interested in quitting. The boxes, the pixels themselves represent a single day. White boxes or white patches represent their normal cigarette smoking. Gray patches represent a 50% reduction in their cigarette smoking. Black boxes represent abstinence from cigarettes. And then most importantly, the little boxes with eyes, the bars in them, represent a day in which they said, I intend to quit today. I intend to quit. So if you can't pick out a pattern from this pixel graph, that's because there really isn't one. The take-home message, I think, broadly from this body of work is that people change quite rapidly. But if you think about what this might mean for one of your patients, if you were to see one of these participants, if they were your patient on any given day, in all likelihood, it would be a day without one of those intentions to quit. And so they would come into your office and say, yes, I smoke cigarettes, and no, I'm not interested in quitting, and go on their way. When in fact, the very next day or the next week, they may develop an intention to quit, but it just didn't happen to show up that specific day. And so for that reason, as clinicians, I think it's really important that we provide interventions and treatment to folks, even and perhaps especially when they come into our office saying they're not interested in quitting now. We want to provide those tools, increase motivation, so that when the time comes, they're ready to take that step and quit smoking cigarettes. And so these types of interventions are often referred to as motivation phase interventions. The term was spearheaded by or coined by Tim Baker, who's at the University of Wisconsin, and has done a lot of work in this area. And the idea behind this, akin to stages of change, but it is the idea that we want to tailor smoking cessation treatments to meet the needs of the person where they are, and in this case, not currently ready to quit. Now, importantly, this often focuses on a first step rather than long-term cessation. We want to get people over that hump of initiating a quit attempt, engaging in treatment, that very first step. Now, bringing this back to the sample population with opioid use disorder, it's worth noting here that very few trials have tested tobacco treatment interventions for people who smoke and explicitly state they don't want to quit at baseline, and none have shown effectiveness. So the data I'll be talking about today are in the broader literature of motivation phase interventions for people who smoke in the general population, with an eye toward applying these interventions to people with opioid use disorder in rural communities. So we talked about motivation phase interventions really targeting that initial step of initiating a quit attempt. And one reason why this is so important is because it turns out that factors associated with taking that first step toward quitting often differ from factors associated with maintaining abstinence from cigarettes. So one way to say this is predictors of quit attempts differ from predictors of quit success. And this was really first brought to light by a seminal systematic review by Vangeli and colleagues, where they reviewed and meta-analyzed nationally representative data from a number of countries around the world, and found, and these are longitudinal data sets, found that predictors of quit attempts were different than predictors of quit success. So we took this idea and said, well, what happens if we look at predictors of quit attempts versus success, specifically among a sample of people who at baseline said they were not ready to quit? So I addressed this with a secondary analysis working with folks at Wisconsin to ask, do these factors differ among people not ready to quit now? So we did a secondary analysis of a factorial trial with a fairly large sample, over 500 individuals, all at baseline said they did not want to quit, but they were daily smokers. The trial itself tested a number of motivation phase interventions, and the treatment lasted 6 weeks. We followed up at 26 weeks to look at predictors of whether they engaged in a quit attempt and then whether they actually succeeded. And here success is defined by 7-day point prevalence abstinence from cigarettes. We looked at a whole host of factors. The models were quite large and complex. I won't get into the details, but what I will talk about are the best predictors that came to the top, meaning they were the best predictors of quit attempts as well as quit success. Remember, among these folks who at baseline said, I don't want to quit, I'm not interested. And what we see is when it comes to quit attempts, the best predictors were time to first cigarette in the morning, both their baseline time to first cigarette, but then also, and importantly, their change in time to first cigarette during the treatment period, demonstrating that in treatment, if we can manipulate that period, it does appear to have some effect on quit attempts down the road. And by time to first cigarette, I mean the amount of time that elapses between when the person wakes up and smokes their first cigarette, which is often thought to be one of the best predictors of nicotine dependence. And we also saw that increases in self-efficacy during the treatment period was another one of the best predictors of making a quit attempt at some point during the study. Finally, we found that there was only one predictor in the model that held true to predict quit success at the end, and this was increases in motivation to quit during the treatment period, which is perhaps not surprising given that we selected this population for people who had very low motivation to quit at baseline. So we were able to identify a few factors that we think are important to target in this population. And the next question is, well, what are the interventions out there? that are actually targeting this and initiating quit attempts among people who were not ready to quit at baseline. So we conducted a systematic review and meta-analysis to collate all of the research that's been done in this area, reviewed almost 2,500 articles, and ended with 25 randomized clinical trials that were included in the review here. Now, this next slide, I think, is pretty telling about the state of treatment research for people who are not ready to quit at baseline. So we set out to conduct one large meta-analysis where we could combine all of the treatments that have been used to promote quit attempts among people who said, I don't want to quit. But what we ended with was a very heterogeneous or a varied group of interventions that have been researched out there, such that we couldn't combine them. It's like comparing apples to oranges. And so we were left with a series of very small meta-analyses. You can see the different treatments here on the screen. We ended with 9 different interventions where we were able to collect randomized clinical trials and conduct a series of small meta-analyses. So in terms of the results, what we found were only 2 interventions, both pharmacotherapies, demonstrated some efficacy in promoting quit attempts among people who said, I don't want to quit. That's nicotine replacement therapy, things like nicotine patch, nicotine lozenge, as well as varenicline, which is a prescription medication for smoking cessation. Now, I think equally important to note here is we conducted what's called a grade analysis of our own analyses to try to identify what's our certainty in the effect here. And as I mentioned, this is a very scattered field. We don't have a consistent treatment base to meta-analyze. And so we didn't have a lot of certainty that treatments that were not found to be effective are actually not effective. Essentially, another way to say this is with more research, we expect that some of the interventions that did not show efficacy could in the future demonstrate effectiveness. That's important to keep in mind here. I also want to pause here for a second and draw your attention to one trial, Carpenter 2011. You might notice has a slightly larger effect size than the others. And I'm going to come back to this when we talk about the tobacco treatment toolkits and what CORA is currently doing in this area. But back to this presentation. So I just told you in our meta-analysis, we found low certainty evidence, but some signal that pharmacotherapy could be an effective way to promote quit attempts in this population. Well, what about counseling? This is something that's recommended, but we didn't see the effects here. Well, I don't think that's reason to throw out counseling for clinics and clinicians who have the time and capability to provide it. It could be a useful adjunct on top of pharmacotherapy, and certainly can't hurt on top of pharmacotherapy. So I want to cover 2 forms of counseling here, given that they're so commonly done and also recommended by the United States Public Health Service. So the first is the 5 R's motivational intervention. And this is the gold standard in terms of counseling for people who are not motivated to make a quit attempt. The idea here is that clinicians work collaboratively with patients to first identify the relevance of smoking and quitting smoking, using motivational interviewing skills that I'm sure many on the call are familiar with. Next, the counseling turns to risks from smoking and collaboratively identifying what the risks from continued smoking could be, really highlighting any change talk or language that the patient uses that talks about change that they could make. The third R here is identifying potential rewards from quitting. This has the potential to be a powerful conversation, thinking about what could be gained if they were able to quit smoking. Common examples are improved health, money saved, and then often people will identify being an example to children or loved ones or family members. Next, the important piece is the fourth R here, which represents roadblocks to quitting. So working collaboratively with the patient to talk about what's getting in the way of making that initial quit attempt or engagement in treatment. And I want to highlight providing advice to quit, which is part of the 5 R's and does differ from traditional motivational interviewing. So here, the U.S. Public Health Service recommends giving direct advice to quit regardless of whether the person is at the point where they say they're interested in quitting. So it has the potential to conflict with the individual here. And then finally, the fifth R is repetition, simply restating these at every interaction with the patient. So let's talk about the evidence behind the 5 Rs. Well, I want to turn to Cochrane reviews, which for those of you who aren't familiar is the gold standard in meta-analysis, where they take all the trials that have been done on a specific topic, pool them to come up with an answer in terms of whether these are currently seen as effective or not. So Cochrane conducted a 2019 review of motivational interviewing, and in contrast to their prior reviews on motivational interviewing, found that there was not sufficient evidence to determine if MI, motivational interviewing, was more effective than no counseling, which came as a surprise to many of us, and calls into question some of the recommendations. However, and this is, I think, an important caveat, there is good reason to think that the 5 Rs, the specific United States Public Health Service recommended intervention, is different than typical motivational interviewing. And I think anyone who's trained in MI would tell you that based on the very brief slide that I presented earlier. There are a number of substantial differences. And so before this presentation, I went back and just pulled the handful of trials that have tested the 5 Rs to promote a quit attempt among people who are not motivated to quit, to see what are we seeing in this very small body of literature. And it turns out there is some pretty consistent evidence here that in 3 RCTs that tested the 5 Rs among smokers not ready to quit, it does increase cessation at the longest term follow-up with fairly large effect sizes here. Which is definitely worth taking into consideration. There's some signal that the 5 Rs per se might be an effective counseling. So we went back and said, well, if there is some effectiveness in the 5 Rs, what are the active ingredients? So as counselors, if you're going to be using this motivational intervention as an adjunct to pharmacotherapy, what should I be highlighting? What should I be focusing on? So we did what's called a mediation analysis, where we looked at a large number of potential constructs that could be the quote active ingredient, or the piece that's allowing 5 Rs to actually have some benefit in promoting quitting, to determine what's going on here. We looked at motivation, self-efficacy, intention to quit, nicotine dependence, as well as a host of interpersonal factors. And the only construct that mediated the effectiveness of the 5 Rs on quitting, or the only quote active ingredient that we were able to find, was the relationship, the working alliance that developed between the counselor and the patient when working on this. And if you think about it, it might not be that surprising. We are working with someone who doesn't want to do something on encouraging them to do that very thing. And so I think there's a lot of potential there to butt heads. And so the interventions that actually were able to develop those alliances appeared here to be more effective in going forward and making a quit attempt. So I want to shift gears here and talk about another very common counseling intervention that's used among patients who are not motivated to quit in the near future. And that's counseling to reduce cigarettes per day. So a common pattern, someone comes into the office, says, I'm not ready to quit now, but I am willing to cut down a few cigarettes. And so that's a foot in the door to provide some counseling around reducing number of cigarettes per day. And there are 2 commonly used strategies we think about reduction counseling. The first is timed reduction. This is where the counselor works collaboratively with the patient to identify the number on average cigarettes per day smoked and the number of waking hours. And then you create a schedule. So if I smoke 10 cigarettes per day and I'm awake for 10 hours a day, I would create a schedule where I smoke 1 cigarette every hour and I don't smoke in between. The idea behind this is to start to break up associations between cues that would have otherwise prompted smoking and the actual act of smoking. So I smoke on a timer instead of in response to things in my environment that would have promoted smoking. And then importantly, we gradually increase time between cigarettes so that we're in the long term decreasing the number of cigarettes smoked per day. The other form of reduction counseling is known as hierarchical reduction. This is where, again, the counselor works collaboratively with the patient. And here they identify a hierarchy of cigarettes that the patient believes is hardest to easiest to give up in a day. And then you make a plan to gradually cut out the easiest cigarettes, working your way up to the hardest cigarettes. And the goal here is to build self-efficacy to quit. So if I'm someone who smokes and I don't believe I can quit, well, if I see myself making changes, if I observe my ability to have some control over my smoking, that could increase confidence, motivation to go ahead and make a quit attempt. So before I get into the evidence on reduction counseling, I want to talk about a few important considerations for those who use reduction counseling. First is there is no standard protocol. So really this is something, this can be anything that's just not abrupt quitting. So there are questions around, well, how much should someone be reducing? How long should they be reducing? And unlike the 5 R's, there is no standard protocol out there for reduction. And then perhaps the most important is reduction counseling. The goal must be abstinence. And this is especially important because more and more studies are demonstrating that most reduction in cigarettes per day does not actually result in reduction in harm, in physical harm. So cutting out 2 to 3 cigarettes usually doesn't move the needle much in terms of the harm that's caused to the individual. What it might do is build motivation to quit. And so reduction counseling is only beneficial to the extent that it leads to smoking cessation or engagement in treatment for cessation. Another way to say this is reduction should not be a substitute for quitting. Okay, so what do we know about the evidence for reduction counseling? So we'll turn back to the Cochrane reviews here, again, the gold standard for meta-analysis. And what we see is that after reviewing over 50 trials that tested reduction-based intervention, there's moderate certainty evidence that reduction works just as well as abrupt cessation, meaning neither is superior. So this is important because when we're working with patients who are not able, not interested, not willing to quit now, but they are open to gradually reducing, well, this meta-analysis suggests that that could be just as effective in the long term to achieve smoking cessation. Okay, so I want to turn back to some of the questions about, well, how much should we be reducing? What should we be working with our patients to do in these situations? Well, we analyzed a daily data set where people at baseline said, I don't want to quit smoking. We followed them longitudinally and looked at who ended up quitting. And specifically, we looked at change in smoking or change in cigarettes per day as a predictor of who ended up quitting. And no matter how we slice it, we saw the same story. So we looked at this in terms of reducing number of cigarettes per day, reducing percent of cigarettes, how much they relative to baseline. We looked at this in terms of duration of reduction, and we looked at this in terms of the absolute final number of cigarettes per day before they attempted to quit. However we sliced it, those who reduced more were more successful. So what this tells us is we want to be pushing or encouraging patients who are engaging in cigarette reduction to reduce as much as they can. Larger magnitudes are better. Okay, so then next we went back and did that same mediation analysis. What are the active ingredients in reduction counseling? What should we be focusing on with our patients to really get the most out of this kind of counseling? Well, first, and perhaps not surprisingly, given the last slide, greater reductions in smoking were associated with better outcomes. So those interventions that can really achieve a large magnitude of reduction appear to be better. And then again, similar to some of those first analyses I showed you, increases in self-efficacy to quit and increases in intention to quit. So this is consistent with the theory that one way that reduction can be effective is by allowing people to observe themselves making change over something they previously thought they couldn't change. So it builds that self-efficacy and intention to go ahead and quit. Okay, so I just presented a whole lot of information, a whole lot of research on motivation phase interventions, or interventions that we can use as clinicians to help people initiate that first step toward quitting when at the outset they say they're not interested in quitting in the near future. So I'm going to summarize what I think are the key points here, the take home. So if you've been dozing off here, you can just tune back in for this next slide, and hopefully this will give you the important bullet points. First is that tobacco treatment for people with opioid use disorder is really critical. Even if they come into the office and say, I'm not ready to quit smoking right now, we still need to be providing some form of treatment. I think one of the most important things to come out of this is demonstrating that pharmacotherapy, like nicotine replacement therapy, is effective. Some of the data I presented earlier demonstrate this in the general population, and then prior meta-analyses show this in people with opioid use disorder. And then importantly, counseling may be helpful, but it really needs to be provided either as an adjunct or in addition to pharmacotherapy, or as a way to get someone on to pharmacotherapy, especially when we're working with people who have an opioid use disorder. So within those counseling, we talked about the 5 R's, a motivation-based counseling, where really it looks like patient alliance might be an important piece there. And we also talked about reduction counseling, where really we're seeing greater magnitudes and then increases in self-efficacy and intention to quit were important factors to come out of that form of counseling. Okay, so now that I've covered that large body of research, I want to talk about what's happening here at CORA. Specifically talking about tobacco treatment toolkits being distributed to treatment providers in the community. So I said I would come back to this trial by Carpenter and colleagues in 2011. And I just want to highlight, the further to the right of that bar there, those little boxes, for those of you not familiar with meta-analyses, represents a greater effect size. And so here we're seeing the effects that we found in our meta-analysis demonstrating NRT is effective for people not ready to quit. Are largely driven by this large trial by Matt Carpenter and colleagues in 2011. And so with that evidence, plus the information I presented earlier, that's used to support nicotine replacement therapy sampling, or NRT sampling. And this is the practice of providing a brief supply of NRT to all people who are identified as smokers or people who smoke cigarettes, regardless of their motivation or intention to quit at that specific interaction. You may not know it, but you are familiar. If you've been to a dentist, you are familiar with this model. So, if you go to the dentist, it doesn't matter whether you intend to brush your teeth or intend to floss, you are leaving with a little baggie of toothpaste, toothbrush, maybe some stickers, but you're just walking out the door with it. And it's up to you to decide. Maybe it sits in your closet, maybe you use it that afternoon. We took Carpenter and colleagues started the similar model, which is being used here in CORA for cigarette smoking. So if someone is identified as someone who smokes cigarettes, whether they want to quit or not, they leave with that baggie of tools to help them quit when they are ready. Again, this is so important given how fluid motivation to quit is. Having those tools ready really helps to achieve smoking cessation. And so some of the data that demonstrate this specific intervention, the effectiveness here, comes from that Carpenter 2011 trial. And just to orient you to this graph, these are people who at baseline were not seeking treatment. And the yellow bars represent those who left with those little grab bags of NRT, and the green represent those who did not. And this was a randomized trial. What we see is that NRT sampling increases treatment engagement. That's that bar on the furthest right of medication use. And while the effects are small, it is clinically meaningful increase in quit attempts, especially when you just distribute these toolkits to a large population. And then most importantly, increase in success at the 6-month outcome. So this light touch intervention, getting pharmacotherapy to those who need it, seems to have some substantial effects, and it's important to be doing with our patients. And so at CORA, that model was adopted, and the tobacco treatment toolkits were developed. And so I'll walk you through what's in a toolkit. Excuse me. So the tobacco treatment toolkit from CORA includes dual nicotine replacement therapy. So that's both long-acting, which is nicotine replacement therapy patch, and short-acting NRT, which in this case is nicotine mini lozenges. It includes educational material and instructions for NRT use, as well as a number of tools to cope with stress, cravings like stress ball, chewing gum, lip balm, and then a participant survey. So I want to walk through quickly what we see as the best practices for nicotine replacement therapy, what's encouraged with these tobacco treatment toolkits. The first is the use of dual NRT. So I mentioned this briefly. This is important because we think that managing nicotine cravings is a little bit more complex than previously thought, where it's important to have an underlying steady state nicotine from the patch, as well as tools to handle breakthrough cravings. So when someone has the patch, but they're presented with a cue and have a craving for a cigarette, it's important to have lozenge or gum handy to use in place of that cigarette. We also encourage pre-cessation NRT, as well as continued NRT during a smoking lapse. So prior to around 2014, the FDA recommended not using NRT while still smoking cigarettes. We now know that not to be true. It's completely safe, and it's actually very important for long-term success to use NRT even before you're ready to quit, or if you have quit and you relapse to cigarette smoking. So this idea of pre-cessation NRT is kind of like testing a parachute before jumping out of, before skydiving. It's good to know what the effects are, how it's going to affect cravings before you make that plunge and make a quit attempt as the person who smokes cigarettes. In addition, it could help achieve some initial reduction, which again, as you saw on previous slides, can help to build self-efficacy and intention to quit, which we know are so important to promoting that initial quit attempt. And then continuing smoking during a lapse to smoking cigarettes or return to smoking cigarettes is important. Sorry, continuing NRT, if there's a return to smoking cigarettes, is important to minimize the amount of time that person continues to smoke. So what we know is return to smoking that happens when someone is wearing a patch is much shorter than if someone takes off the patch when they return to smoking. So who's getting these tobacco toolkits? So this is a bar graph demonstrating that CORA has distributed over 600 of these toolkits to providers in rural communities. And there's a wide range of providers that are receiving and distributing these tobacco treatment toolkits, from rural community hospitals to tribal organizations to methadone clinics, mental health and behavioral organizations. So it's really distributing widely here. And also the folks who are the point person, who are receiving these tobacco toolkits from CORA and then distributing them to patients vary quite a bit. Which I think is a really good thing. We want these to be getting out wherever there's a point of contact with a patient who has opioid use disorder and smokes cigarettes. So we see nurse practitioners, recovery coaches, medical doctors, and program managers, wide range of people distributing these toolkits. So who is eligible for tobacco treatment toolkits? Well, the clinic must be in a rural or partially rural county. Here's a map of our region here on the screen. Must be prescribing medications for people with opioid use disorder. And the toolkits themselves come with a list of contraindications so that providers can determine who should be receiving toolkits with NRT in them, or who has contraindications for NRT. And then there are some ideas for problem solving to get those folks treatment. So I will end there after having given you a summary of what's happening here. If people are interested in tobacco treatment toolkits, you can see the email to contact there on the screen. And if you have questions about the talk, I think we have a few minutes now, but if we don't get to all the questions, I'd welcome any emails and would be happy to talk to you about this important work. Thank you.
Okay, I will go ahead and share my screen again. So thank you very much, Dr. Klemperer, for this really excellent presentation, and thanks to everyone who joined today. I have a couple of things to go over before we take some questions. Firstly, I am going to launch this very quick poll. It's 4 items, and we would love to have you fill it out. It should take less than about a minute, and I'm just going to wait here for folks to do that. And once people start, we have a bunch of people who have answered it, we'll feel like we can do our evaluation. So that's great. And then we'll get to questions in just a moment. All right, we'll do about 5 more seconds here. Okay. Thank you very much for doing that. Now, you will receive an email next week with the recording and the slides for the webinar, as well as instructions on claiming community or continuing education credits. And we are sharing that information in the chat as well. And lastly, you may know that CORA is one of 3 rural centers of excellence. The other 2 centers are Fletcher Group, which is located in Kentucky, and the University of Rochester in New York. And so if you are interested in checking out those centers, you can see all the great work that they are doing. So I will now hand it over to Ashley Mallett, who will facilitate your questions.
Thanks, Jenny. So we have a lot of interest in the tobacco toolkits. And so I am going to start there just because I know we have a few minutes. If you submitted a question and we don't get to it, I've got them all copied down and we'll get emails out to everyone. But one of the first questions that came up was if you have any advice for distribution of the tobacco treatment kits or toolkits through a syringe service program that does not offer medication for OUD.
Yeah, that's a great question, and I think so important to make sure that folks who are maybe not engaged in medication for opioid use disorder also have tools to quit smoking. And I think the important thing is to make sure treatment is as low barrier as possible, which is, I think, one of the benefits of these NRT sampling, or the model used behind these tobacco treatment toolkits. Counseling has its place, but for people who are not interested in treatment, simply providing a grab bag of NRT or treatment resources can be effective and helpful and move the needle toward quitting, and is important. And so I think using an opt-out model might be useful there, where rather than asking if someone's interested in quitting and only then offering treatment, simply providing the treatment resources, whether they've asked for it or not, and then it's up to them whether they throw it in the trash, leave it there on the counter, or go ahead and actually use it and make a quit attempt. But yeah.
Great, thank you. And again, about the tobacco toolkits, what are your recommendations for pregnant patients with co-occurring tobacco use and OUD to reduce the potential effects of NAS?
Yeah, so this has actually been an ongoing conversation here, and I don't have a great answer for you right now, and I'm sorry for that. But one thing I can say is I think important to manage on a case-by-case basis, and if possible, looping in the patient's primary care physician to talk about the risks versus benefits of using nicotine replacement therapy, which often can be important to use for in people and women who are pregnant.
Great. Is there any interaction between tobacco treatment, medications, and opioids?
Yeah, that's a really good question. So there's some evidence that nicotine and opioids have a pharmacological interaction in the brain. And I don't know of the research on nicotine replacement therapy per se and opioids, but we do know that pharmacotherapy on the whole appears to be, in large data sets, broadly speaking, not at the individual level, but broadly speaking, appears to be less effective among people with opioid use disorder in comparison to the general population. Now, that statement comes with a number of caveats, but important to note there that it's not clear why that is. So that could be drug interactions, likely a lot of environmental influences, or also co-occurring disorders. But it's a good question.
Great. And how does this relate to vaping nicotine or even smoking or vaping THC for cannabis?
Good question. And I'll address those separately. So I think it's important to think about vaping nicotine and cannabis sort of separate here. No, I think being a proponent of harm reduction here, we need to think about the difference between combusted tobacco products, which is where a lot of the harm from smoking comes from, versus nicotine. And so anytime we can switch someone over from a combusted to a non-combusted product, that's a win in terms of harm reduction. So if that means switching someone from smoking to exclusive e-cigarette use, that's harm reduction. If that means switching someone from smoking to nicotine replacement therapy, that's even more harm reduction and even better. But I think it's important to think about that on a continuum where we really want to get people away from combusted tobacco use.
Great. How do health professionals working with persons with OUD effectively promote tobacco cessation and harm reduction when Vermont's health department does seem a little hostile to the growing body of science on the role of e-cigarettes?
Well, it's a politically charged topic wherever you go in the United States, and I think it's important to recognize that I would say we all want the same thing, which is improved health for our patients. How to get there is a question, and I think today's talk was really about talking about pharmacotherapy or approved medications, which does not include e-cigarettes in the United States. But I think there is an entirely different talk to be given about the role of e-cigarettes in reducing harm from combusted tobacco. And the evidence suggests that it does do that. And that's really important to do to reduce harm from combusted tobacco. Although I think probably the question is getting at political barriers to doing that, which is something that I think is sort of a moving target that we're actively addressing here.
Great. And I have one more for you. We have a participant who works in public health, but is not a provider or clinician. And they would like to know if you have any recommendations on how to elevate the need to address tobacco use for providers who are treating populations with high prevalence of SUD and mental health conditions, and they might feel overwhelmed by competing priorities or view tobacco use as a fairly low priority.
Yeah, that's such an important question. I think it depends at what level you're working at. At the individual level, sometimes education can be really powerful. Knowing that 50% of people who smoke cigarettes will die from a smoking-related cause of death. That's powerful. That is a staggering number and leaves you with a lot of room to improve health simply by engaging in smoking cessation treatment. Knowing that smoking cessation does not disrupt treatment for substance use disorder or opioid use disorder is important. It could alleviate fears that many clinicians have that, I need to focus only on my patient's illicit substance use, and we'll worry about smoking maybe someday, if ever. Well, it's not the case. What we find is actually smoking cessation helps achieve those other goals. And so that can help at the individual level, talking to clinicians as well. At the systems level, I think it's a bigger question, but I think education can help there too, if you can get people on board with the need to deliver these. And one final thought on that is that I think that's one of the strengths of these light touch treatments. We're seeing evidence that simply distributing a baggie of NRT is helpful. And so for clinicians who are very pressed for time, or systems that may not have the resources to deliver lengthy interventions, simply offering a bag of NRT can be a light touch and effective intervention for people who smoke cigarettes.
Great, thank you so much. We did have a few more questions. I've captured everyone's information, and then we'll get emails out to you, but Jenny, I'll turn it back to you.
Thank you. Thank you, Ashley. Thank you so much for this wonderful presentation, Dr. Klemperer. We are having a lot of thanks coming into the chat as well, and people have really appreciated the information. We will do our best to follow up with everybody who have questions that weren't yet answered. And as always, you can contact us at cora@uvm.edu, and we really appreciate you joining. Have a great day.